Yeah. Abdominal pain, we've got PV bleeding, discharge, vaginal bleeding. Yeah. So I will go through some of the ones that I thought were quite common from what I'd seen, which are, so changes in vaginal discharge. And this is things like changes in the colour, the consistency, or the smell of discharge. Most of this is largely due to STIs, which I think Anusha's going to cover with you. Am I right, Anusha, saying that? Well, I think Anusha's going to cover that.
Sorry, what was that? You're just breaking up a bit.
Oh, I said, are you going to be covering most of the STIs and the gum stuff?
Yeah, we'll cover that at some point, but yeah, that's super important in gynae as well.
So mostly discharge changes are caused by STIs, but there are other things which you will, throughout the series of the lectures, you will become aware of. There are other things that can cause discharge changes, but mostly think about UTIs when you see someone coming in with that presentation. Not UTIs, sorry, STIs. So pelvic pain, as someone says, pelvic pain is a really, really common presentation. So pain around periods and during your period, but also some people get cyclical pain, so they might get it before their periods or mid-cycle or just randomly. And that is a common presentation to look at, especially if someone comes in and they might be pregnant and you want to worry about, have they got pelvic pain and could it be an ectopic? The next one is menopausal symptoms, so things like hot flashes and vaginal dryness. So all women go through menopause, and lots of women find the symptoms really bothersome, so they might come in reporting those and wanting treatment or help with them. And then abnormal pain or painful menstrual bleeding. So periods changes are quite common, and there are things that can cause changes which you need to know about, which we're going to go through in another lecture, I think the next lecture. But yeah, so period changes, what you need to know, what causes them, and different types of changes. So heavy bleeding, painful bleeding, and then bleeding between periods, bleeding after sex, and that kind of thing. So then fertility issues. So women might come in having tried to get pregnant and been unable to get pregnant. So that is quite a common presentation, and there are lots of different conditions which can cause what we call subfertility, which you need to know about. And it's probably not something you'll see very often in clinics, but it is a present, like you need to know that certain things can cause subfertility or make it more difficult to conceive. And then lastly, prolapse and incontinence. So this is something that normally comes around the age of menopause or after menopause. Women may start to experience prolapse and then incontinence, and it also goes quite strongly with childbirth, so relating to the number of children women have given birth to and how they gave birth. Okay, so as I said, the gynae history is something you need to ask about, and it's normally, well, the way I learned it is in 6 main parts. Yeah, incontinence comes up in Jerry's a lot too. It's one of the main things, so heads up for that. Comes in 6 main parts. So gynae history, you need to talk about past gynae history. So what has the woman had in the past? Menstrual history, cervical screening, sexual history, contraception, and obstetric history. So what we're going to do is go through each one of these separately. So we're going to start with past gynae history. So can anyone name any gynae conditions? I know most of you probably haven't started yet or done much work, but any conditions that you can name? PCOS, yep. So PCOS is polycystic ovarian syndrome, which is a big condition. Endometriosis, pelvic inflammatory disease, fibroids. Okay, so you want to basically ask a woman, after you've taken the history of presenting a complaint and asked about why she's come in today, you want to say to her, have you been diagnosed with any gynae conditions in the past, or have you seen a gynecologist before? Something like that, where you're inviting them to tell you about something that they've been in with before, and you want to basically find out if they've got any previous conditions. So these are some that I thought about. STI, I know it's not really a gynae condition, but you want to know, and we'll come on to it a bit later in sexual history, but you need to know about it because it could lead to complications like PID, which is pelvic inflammatory disease, PCOS, and then ectopic pregnancies and endometriosis. So these are just some examples, and there are loads more like fibroids and polyps and other things, but you basically just want to ask the woman if she's been to a gynecologist before, or if she's had any gynae conditions before, or got a gynecological diagnosis. If they do, you want to ask about how it's treated, because you need to know what they've been treated with and has it worked. You also then want to ask about surgeries, if they were treated with surgery, because as I heard before, surgery can cause adhesions, and adhesions are important in causing other gynae complications. So just make sure you ask about treatment and surgery. And then if a woman is slightly older, you might want to ask about menopause. So you want to ask about the age of menopause, and you also want to ask about what treatment they're on. So you don't need to worry about that so much in younger women, but if a woman is older, you might want to think about asking about that. So that's the past gynae history. The next section is the menstrual history. So obviously don't ask about menstrual history if you just found out the woman underwent menopause like 4 years ago, because it's completely irrelevant now. So, but if they are younger and haven't been through menopause, you want to ask about the menstrual history. So there's two parts to this. You want to firstly ask about physiological factor or parts. So you want to ask about the first date of their last menstrual period, and it's important you ask about the first date, not the last date, which has confused me for quite a long time. But you ask about the first date of their menstrual period, and lots of them will probably have to think about that. Then you want to ask about the regularity. So how many periods they get a year, or how often are their periods? Do they come regularly? And then, as I said, the duration of the cycle. So, which goes in hand with regularity. So some women, if their cycles are really irregular, they may not really be able to, they may not have a set duration, so their cycle length may vary every month. But normally their period length will stay the same. So you want to ask about how long their period length is and how long their cycle is. And this is important because different conditions can cause changes in this. And some women, for some women, it may never be regular, and some women it may be regular, and then it starts to become irregular, which might be why they've come in, because they're worried about something. So the other part is the pathological problems. So this is, well, dysmenorrhea and menorrhagia. Can anyone tell me what either of those mean? Yep, so menorrhagia is heavy bleeding, and which is you usually do by the woman. So if the woman comes in saying she has heavy bleeding, you usually take it as that she has heavy bleeding. There used to be like a measurement for it, but then people decided that was a bit silly. So yep, and then dysmenorrhea is painful periods. So you basically, some women may tell you they have this, but some women you need to ask about it for. So you want to find out if their periods are heavy or painful, or also this could also be the reason they've come in. That might be why they've come to see you today. So, and then you want to ask about instrumental bleeding, which is basically what it says. It's bleeding between periods. So do they experience that? Postcoital bleeding is bleeding after sex. So again, it's not usually common. So you want to ask about if they've had that. And then vaginal discharge, which we said before, is mainly UTIs, but not UTIs, STIs, but not always. So you need to ask about that as well. Okay, now cervical screening. So this is quite important to ask about, and all women will, after the age of 25, will be eligible for cervical screening. So you need to ask about the last date of their smear and its outcome, because they're usually every 3 years from the age of 25. So you want to ask when they had their last one and what was the outcome. And then you need to ask about if they've had many smears before, have they had any abnormalities previously in their smears, and if they did they require a colposcopy or did they require any treatment? This is important because it lets you know, for example, a woman might be slightly more high risk for then having more abnormal cervical smears in the future, but also you might be more concerned about things like cervical cancer. And then lastly, you need to ask if they've received the HPV vaccine. So most young people hopefully will have got that, but it wasn't really a thing until recently. So most older women will not have received that. So that's something to bear in mind, that older people probably won't have it, but younger people like our age should have done. Any questions about any of that so far? Okay, so the next part is the sexual history. When you guys do gum, which some of you might already be doing or doing soon, Dr. Cartledge will teach you how to take like a proper, really good sexual history, which you do not need to repeat for your gynae history, because in itself it is like a good 10-minute exercise. So you just need to know the key points to ask here in your gynae history. Can anyone think of what they might be? Yes, the first question is, are you sexually active? Because you need to ask that first, because there's no point asking all these random questions and then finding out the woman's not sexually active. So you need to ask about sexual activity. So firstly, you just start by saying, can I ask if you're sexually active? But sometimes it's good to say, I'm going to ask a few more sensitive questions now, or personal questions now, just to signpost what you're doing, so you don't kind of shock the woman when you start asking about her private life. So you can signpost it if you want to, but it's quite a good thing to do. That's quite a good thing to start by doing. So then you want to ask, is she sexually active? If she says yes, continue. If she says no, don't bother asking anymore. So we want to ask about present partners. So does she have a regular partner or a casual partner, or casual partners? And this is important because the idea behind it, whether it's true or not, is that regular partners are less likely to pick up an STI or something like that, whereas casual partners might be more at risk to. Obviously, it's a flawed system, but that's the general idea of the question. Then you want to ask about the number of partners in the last 3 months. So this gives you an idea of, the chances of the woman having an STI or something like that. That's something that you will do in your GYN histories as well. So you just ask what number of partners. If they've had one, then you know it's a slightly less risk, but obviously it's a flawed system. The next one you want to ask about is if they had any previous STIs and when was their last test. For example, if a woman, her last test was 6 months ago and she's had 4 different partners in the last 3 months and she's coming in with vaginal discharge, that's lots of red lights, and you want to be thinking about STI testing her, because with the history of changes in discharge and having lots of different partners and not having a recent STI test, she could have an STI, and so that would be the first thing to do. And the next one is dyspareunia. Does anyone know what this means? Yeah, it means pain during sex. So you basically want to ask about this. Most women will probably not openly tell you about it. So you want to subtly ask about it if you can. Again, say it's a more personal question. This is a sign of STIs, but there are some other diagnoses like endometriosis that can also cause this. So it's a good thing to ask about because it can lead you into other areas. Okay, the next one is contraception. So there are many types of contraception. What I would say is don't worry about them all because, as it says here, I'm going to cover them with you next time we do a session. But basically, you just want to ask someone if she is on any contraception. So it might be good by saying, do you use condoms and do you on any contraception? Because some women will not take condoms as proper contraception, but some women may be on both, for example. So it's a good thing to ask about condoms and contraception. And if a woman is not, you want to ask why. So she might be trying to conceive, she might not be sexually active. They're not the only reasons, but it's a good idea to ask why, because obviously if she says I'm not using them because I'm not sexually active, then that rules out a lot of different possible pathologies. So it's a good idea to ask why. So the next one is the obstetric history. So you want to ask about previous pregnancies. Basically, you want to ask if the woman has been pregnant before and what was the outcome of the pregnancy. So you want to work out the G and the P that we did earlier, because that's useful. So then you need to ask also about terminations and miscarriages, and as someone said before, stillbirths. So that is a good thing to say. I'm going to ask some more sensitive questions now, or personal questions now, and signpost it, because obviously it can be somewhat upsetting for some women. So that is a good thing to do. And then it's also important to ask about fertility problems, because as I said before, some conditions can cause fertility difficulties. So have you had any trouble conceiving or difficulties conceiving or that kind of thing? Or if a woman says yes, you want to know if she's used IVF before, that kind of thing. And if she has got pregnant, so ask if she's used IVF. Okay. Right, so now we're going to go on to the obstetric history. So are there any questions about the gynae part before we move on? So as I said before, everything else that you do is just the same as a normal history from last year. You just need to make sure you add in the gynae parts. So for example, if a woman comes in with pelvic pain, you need to Socrates her like you would have done before, and then finish your presenting complaint up and then ask about her gynae history and her sexual history and that kind of thing that we've just gone through.
I think it's just worth pointing out now, when in regards to sensitive questions, there's a lot of CPP stuff in women's health, like FGM and safeguarding during domestic violence and things like that. And we're not going to cover that because I think it's actually covered pretty well in the curriculum. You'll get teaching on it. I think Jess agrees. It's taught really well.
It's covered really well. It's Jane, I can't remember her name. She does it, but she covers it really, really well, which is why I've not really touched on it here. But she goes through it and you practice doing histories with hopefully and that kind of thing. So she does it really well. Okay, someone has asked, how do you do it all in 10 minutes? So you have to practice. We'll come to this at the end. You have to practice. And you also kind of can work out what are the questions that you need to ask. So if I just go back, for example, if before you've asked about and you know a woman's had an STI when you asked about her past gynae history, then you might have already covered some of the sexual history components before, and you might not need to do it again. So you just kind of work out where, you don't have to do it in this order, work out where it fits best in. So, for example, you could always do contraception. When you ask about that, you could ask about contraception and other drugs, because lots of women won't include contraception as a normal, regular medication. So you could always do the rest of the drug history then and find out ways to make it work for you. But yeah, you just need to practice squishing it all down.
It's definitely doable. It's super doable.
It is doable, but you just have to practice, because it is a lot to cover to start with. And I just think last year when you first learned how to do a history, it seemed really overwhelming. And this is not quite so overwhelming, but is a similar thing. Right, any more questions? Okay, so for the obstetric history, you basically do the same thing. So the woman has come in, you take her presenting complaint, and then you ask about the history of that. Then you need to work out the history of the current pregnancy. So you need to go through the pregnancy, which we're going to do in detail, and ask about all the different parts of this. And then you just go into past medical history, and in that you can do a tiny bit about the gynae and a tiny bit about the obstetrics. And then again, you do need to ask about surgery. It's not quite so important as it is in obstetrics, apart from C-sections, obviously important, but you should hopefully find that out in obstetric history. But yeah, so everything else is just the same, apart from you need to ask about past obstetric and gynae history, and then go into the current pregnancy in detail. Okay, so can anyone think of any obstetric presenting complaints? Anisha, is that you? Start facing it. Yeah. Yes, a reduced fetal movement is a very good one. And when you get to labour ward, it's a very common thing that you will see women coming in for. Contractions. Yes, that is a presenting complaint. You might get women coming in with abdominal pain, worrying it's contractions, or not knowing, if they've not given birth before, they might not know what contractions feel like. Bleeding, yeah, so these are all super good ones. So nausea and vomiting, very common in pregnancy, and in most women, so lots of women do experience nausea and vomiting, and in most women it's not usually a problem. In some women it makes them very, very unwell. So if someone comes in with that, you need to ask about how much they're vomiting, can they keep anything down, that kind of thing. And you want to screen for dehydration, basically, because some women who are really dehydrated from vomiting will need to be admitted. So if someone comes in with that, you want to screen for things like dehydration and weight loss, and then find out actually how much food are they able to eat. Urinary symptoms. So with pregnancy, you can get UTIs, and UTIs are bad in pregnancy. So you want to ask about, so if someone comes in with this, you want to ask about things like you would for a normal UTI, so pain, frequency, changes in smell of the urine, that kind of thing. But you also have to remember, women will go more frequently as they get more pregnant, because the baby gets bigger and squishes their bladder. Then reduced fetal movement, as someone said. So usually the fetus starts to move around 18 weeks, or the mum should be able to feel it around 18 weeks. So you want to ask questions about how often they've been feeling it, does it change, that kind of thing. And you should remember that a woman who's pregnant for the first time, the fetus might move slightly later on, so normally around 20 weeks. So that's just something to bear in mind, but it's not really that important. Bleeding. Yeah, so bleeding is common in pregnancy, and there are lots of different things that can cause it. And bleeding often makes women very concerned. So that is something you need to be asked about, and just do it like you would do a normal history from last year. Then spontaneous rupture of membranes. So this can be a sign of labour, but can also not be a sign of labour. And a woman normally describes this as like a gushing sensation, or like something popping. So you need to basically ask about that, and then ask if they've had any symptoms of like infection, so temperatures, fevers, that kind of thing. Because if we have spontaneous rupture of membranes before women go into labour, they could get infections, which is not good. Itching. So there are some obstetric conditions which can cause itching. So you just want to ask about, like, where is the itching? Is it worse at night? That kind of thing. And then abdominal and pelvic pain. So this could be contractions. This could also be other things. So you need to Socrates the pain to try and differentiate between contractions and something that's more sinister. Now that looks like quite a lot of stuff to go through. Hopefully over the course of the lectures that I do and through the teaching you have at uni, you should be able to put into place all the different conditions that can cause these. So don't worry too much about all of that for now. Okay, so the first thing you want to do after you've taken the history of present and complaint is go through the history of the current pregnancy. So the easiest way to do this is to split it up into the different trimesters, first, second, and third. So the first trimester is 0 to 12 weeks. And what you want to do when you first see a woman after you've taken like the present and complaint, or I used to do this right at the very start of the history, is ask how far along she is. Because if you find out the woman is only 7 weeks, you just ask about the first trimester and stop. Whereas if you find out that she's 38 weeks, you need to go through all 3 trimesters. So the most useful thing is probably at the start. So once you've asked the name and date of birth, if you see a pregnant woman, ask how pregnant she is, well, what her gestation is. So then you want to ask, how many weeks gestation are you? So if they're less than 12 weeks, you want to ask the first date of their last menstrual period and if their periods are regular, because that will give you a clue about their gestation. So women normally have their booking scan, which will date the pregnancy around 12 weeks, 10 to 12 weeks. So some women who are less than 12 weeks won't have had the official scan yet, so they won't officially have the date of their, like, how old their baby is. So if they're less than 12 weeks, the way you would do it is doing this until they get the scan, and when they get the scan, they come and work it out. So you want to work out the estimated delivery date, and then you want to know if it is a spontaneous conception or if it's IVF. This is because IVF pregnancies are more at risk of certain conditions. For example, like abnormal placentation, you're more at risk with IVF. Antenatal care. So you want to know if they're consultant or midwife-led care. So if they're consultant care, it indicates that the woman is high risk for something. So most women are treated by midwives, but for example, if they're at risk of diabetes or if they're at risk of hypertension, or if they've got twins, they might be treated by a consultant. So if you ask about this, it gives you a good idea about how worried the obstetric team are about the woman. And then you want to ask about the tests they've had. So the dating scan, as I said, is normally between 10 and 12 weeks, and it basically, as it says, dates the pregnancy and works out how old the baby is. Then the booking bloods is a blood test that all women get at the start of their pregnancy. So this looks for things like anemia, as well as their blood group, and then some things like HIV and syphilis. And it's a good idea to ask about this because you want to know if they've had any abnormalities in their blood or if they're anemic and things like that. And then the combined test. So this is the test for Down syndrome, trisomy 18 and trisomy 13. It's normally done with the dating ultrasound scan. It's like part of that. And you just want to ask about this and if they've had it done yet. And then you want to ask if any anomalies are found in any of these, because this could indicate that could be a contribution to the presentation the woman's come in with. And then complications. So bleeding, have they had experienced any bleeding so far? Have they had any UTIs? And have they had any hyperemesis, which is basically severe nausea and vomiting that I told you about earlier, which causes really bad dehydration. Okay, any questions about that? And I know that seems like quite a lot, but you'll work out how to do it quite quickly and how to go through. And it's just easy if you ask things like, have you had any tests yet? Yes, they do. They emphasise combined test result analysis and teaching. You do need to work out how to interpret that. It's not important for histories, but it's important for like SBAs and just other things in general. So with test, you, for example, could just quickly ask about the scans they've had and then ask about anomalies and try and do it in like a more condensed form. Yes, Anush?
Yeah, I was just going to say that pregnant women know their health really well. So when you start asking questions, they'll give you more information than you ask for most of the time because they know the questions that are being asked. So it doesn't take very long at all. They're very on it.
So second trimester is 12 weeks to 28 weeks. So you want to firstly ask about scans. So normally you get the anomaly scan around 20 weeks, and this literally looks for anomalies in the fetus. So you want to ask if they've had the scan and if what was found. And you want to ask if they have any extra scans. So if this is things like a cardiac scan, so a more detailed heart scan, which could be done because they saw an anomaly on the anomaly scan, but it could also be done if the woman's high risk. So if she has a heart defect herself or her partner does, her previous baby has, if she's diabetic, you might do it, and if she's on anti-epileptic medication. So you want to ask if she's had any extra scans because it could indicate that something is wrong or they're concerned that something's wrong. Then complications. So again, just ask. What is best to say is ask if they've had any complications in the pregnancy. And as Anish said, most women who are pregnant will literally just come out with what they've had. You don't need to normally list them all. But this is things like bleeding, hypertension, anemia, UTIs, and fetal growth. So some babies are small and some babies are extra large. And if they are, they normally require additional scans. So you might want to ask about if they will normally tell you though that, oh, my baby's small, or they might say, oh, I'm having extra scans because my baby seems large, that kind of thing. And then fetal movement. So as I said before, it starts around 18 weeks, and you just want to ask, is the fetal movement regular? And lots of women, if they come in, this might be a reason why they've come in the first place. So you might not even need to ask it here because you might already know, but they will usually tell you. So third trimester is 28 to 40 weeks. So basically the last weeks until birth. So you want to ask about the glucose tolerance test, which is a test to diagnose gestational diabetes, which is basically diabetes that you get in pregnancy. It's normally done around 28 weeks. So you just want to ask if a woman's had that done. It's not done in every woman. It's only done in certain women who are deemed high risk. So not all women will have had it done, and some women may have had it earlier. If they've already had gestational diabetes in the past, they're going to have it early. And then, as I said before, some babies who are big and some babies who are small will get additional growth scans. So at 28 weeks, you do one then, you do one at 32 weeks and one at 36 weeks. So you want to ask about these and see if they've had any scans. But as I said, if you ask if they've had any complications, the woman will usually tell you this. And then she might say, I'm having extra scans. Or if you ask what scans they're having, women will normally tell you, oh, I've got one in 2 weeks' time. And if they're already at 28 weeks, they wouldn't normally get a scan then. So you know that it's because of something, so you can ask why. So the complications are the same as previously. So you don't normally need to ask about them all again, but you want to ask if they've been diagnosed with gestational diabetes, if they've had the glucose tolerance test, and if they've had any membrane ruptures. Most women who've had membrane ruptures you'll probably know about, and they will probably be in hospital or they'll be having regular monitoring. And then fetal movement again, and then delivery plans. So from about 28 weeks, women should start to think about how they're going to deliver. It's useful to ask this because if they are having a C-section, for example, it indicates it could be a reason why. So some women may have reasons why they have to have it, like they might have a gynae pathology that means they need a C-section. There might be a problem with the baby that means they need a C-section, that kind of thing. So ask about delivery plans. Okay, so does that all make sense?
Before we go on, what test can you not use for gestational diabetes in people that are pregnant? This is something they like emphasizing in the curriculum as well. Does anyone know? HbA1c in particular, is not reliable in pregnancy because of changes in red cell. Sorry, go on, Jess.
Well, as Anish said, it's changes in red cells, but also because it's a few months back, and your hemoglobin, it all changes as you become pregnant, so it's not a good indicator, and you don't normally use it until at least 3 months postpartum.
Mm-hmm. So a big problem at the moment is because of COVID, they are relying on HbA1cs in pregnancy, and they're completely missing gestational diabetes. So just remember for exams, don't use HbA1c in pregnant people.
Okay. Any questions about what we've just gone through so far? Okay. So the last few bits now, we are very nearly done, is past medical history. So once you've asked about their general past medical history, you want to ask about obstetric history. So basically, you just want to know if the woman's been pregnant before. If they have, you want to ask about the gestation of the delivery, basically. So you want to know if the baby was early. If the baby was early, there is a risk factor. So if they were very premature, they're more high risk of having another premature delivery. But also the baby might have been premature because they were induced for some reason, and that could be because of a condition that they might have this time. For example, the baby could be really large, in which case you're worried that this baby may also be large. So that's why you also want to ask about the birth weight, because if they had one large baby, it could indicate that the next baby is going to be large. It doesn't always, it doesn't normally, doesn't often work like that, but it would be something to look out for. And you want to ask about the mode of delivery. So spontaneous vaginal delivery is about what SVD means. So was it just a normal delivery? were they induced for some reason? Did they have an instrumental delivery, or was it a C-section, and was it an emergency C-section? As I said, this just gives you some indication as to what could happen in this pregnancy. And if someone's had a past C-section, if they want a vaginal delivery this time, you need to be more careful. So it will just give you a good idea into kind of the care they're receiving, and also if they're more high risk for certain things. And then you need to ask about complications. The easiest thing to do is just say, did you have any complications in your previous pregnancy? And as Anu said, most women who are pregnant are very on it, or they're on it because they're pregnant, and they will therefore reel off all the different things they had. So gestational diabetes, hypertension, preeclampsia, preterm labour, or postpartum hemorrhage, they can normally say. And you might want to ask if the baby had a NICU admission, or the easiest way to ask that is, did the baby go home straight away? And if they didn't, the mother will usually tell you no and all the information about why. Then you want to ask about the past gynae history. So just really quickly, you just want to ask about the cervical smears. So when was the last smear and what was its outcome? When is the next one due? Women tend not to get smears done while they're pregnant, so they usually say to delay it until after pregnancy, which is why it's important to ask when the next one's due. And then you want to ask if they had any abnormalities previously, did they have a colposcopy for it, and did they have any treatment? And then, like we said before, you want to ask about if they've had any past gynae conditions. So these are not so much important for once a woman is pregnant. They more play a role in the getting pregnant. So they're not as important now that they're already pregnant, but it's just useful to know. For example, if a woman has fibroids and she might have a massive fibroid which could obstruct the birth canal when they're trying to give birth, it's very, very rare and not very common, but it's something just to be aware of. Okay, so that is basically what the extra bits that you need to do for an obstetric history. And then once you've done that, you just go back through and ask about the drug history, the other past medical history, family history, all that kind of thing. It is worth noting that sometimes it is important to ask when you ask about family history. Some women who have a family history of things like preeclampsia, so you could specifically ask that, were there any complications when your mother was pregnant, for example, or did your mother have preeclampsia? That's a very specific question, but it is something to be aware of because family history for things like that is important. Okay, are there any questions, or have you got any general obstetric or gynae questions? If you have, put them in the chat.
Might be worth mentioning where it's good to clerk patients in terms of hospital places.
Okay, so I did my placement on the Royal Free, and I would clerk people there. There is the gynae. So when I went to is it the early assessment unit?
Yeah. So the way these departments are set up, you'll find gynae inpatients hopefully. Although a lot of those might be telephone, like gynae is easier to find in clinics, but now there are a lot of telephone clinics, so that's a bit of a challenge. But in terms of obstetrics, you can find people who are both prenatal and postnatal, not prenatal, antenatal.
So what I would do is people who are pregnant, so there's often like wards of women who are about to go into labour. So lots of them will, if they're not, so some women, a lot of women I clerked had come in to be induced, so they were literally just like waiting for labour to start, and were more than happy to talk to you. So that's a good place to go. So this is not the labour ward. This is like before labour ward, basically. That's a good place to go to. And then also there's on that ward you'll probably find women who've just come in for other things. So there was a woman I saw there who had come in for bleeding, and another woman who'd come in for hyperemesis. So they were much like less far along in their pregnancy. They were nowhere near giving birth, but they were useful to talk to because they were a very different end of the spectrum. So that's useful. And then gynae patients, hopefully there'll be some gynae inpatients that you can talk to. And my advice for taking a history is, and the first few times you do it, write like a checklist of the things you need to include. And take it with you and just look at it. If you're saying and I would just say to the patients, oh, I'm really sorry, I'm just making sure I've covered everything as I looked at it. Or if you're allowed to, I'm not sure if you will because of COVID, if you can bring a friend with you. They're useful because they can tell you what you've missed. And also you can watch someone else. So if you can't, that's a bit annoying.
Yeah, I think they're a bit iffy about having multiple people at the bedside. But it's a good time to be practicing history taking because patients aren't really allowed so many relatives in, so they're really bored and they just really want some company. So, like, I mean, if you take a history and spend some time with them, like, they're usually pretty like happy, as in it makes them feel a bit happier as well. It's kind of sad for them.
Are there any questions? But it does seem like a lot, so you just have to practice it and work out what is for the woman most important to, like, which were the most important questions to ask about.
Yeah. Like, you'll be really good at it by the end of your placement, I assure you. I mean, provided you don't not turn up for 6 weeks, and then maybe not so much, but like, that's always the case, right? Yeah, if you could fill out feedback, that'd be super useful, because like we use the feedback to kind of guide where we're going with the next, what we're going to cover next. So it's useful to get that. I hope everyone's having a good placement so far, because you've been in what, for like a week now, right? Jess, how's having nothing to do at Basildon? Oh wait, let me stop the recording there.